effort. Actually, we should thank you for making it happen.
Well, the person who really needs the thanks is Ruth because she did this before and she did a beautiful job with the first series. So I'm just following in her
Luna,
little stilettos.
I
Okay, ladies, we must start. Thank you for everything. Kathleen, you are the one.
Thank you, everyone, for coming here today on Saturday and joining us. I am here with my friends and my colleagues. I welcome you to the Empower Her series of Vein and Lymphatic University. Today, we will be discussing diversity. I am Kathleen Osvath. I'm Chief of Surgery at Samaritan Hospital, and I'm joined by my friend and co-moderator, Ruth Bush, who's the Associate Dean of Medical Affairs at UTMB. She's the Madam President of the American Venous Forum and also the executive editor for JVSVLD. And our co-moderators who could not be here today include Rebecca Riachi and Lena Vargas. First, I would like to welcome our esteemed speaker, Misaki Kiguchi, who is a vascular surgeon and program director at MedStar Washington Hospital Center at Georgetown University. Misaki, thank you so much for joining us, and we can't wait to hear what you have to say.
Thank you so much, Kathleen. I'm really, really excited about being here today. I'm going to share my screen. It's a cold fall day here in Washington, D.C., so hopefully it is a little bit nicer to where everyone is. Hopefully everyone can see my screen. What I really wanted to start off with is a sort of discussing about geographic and social economic factors affecting access to venous care. Here are my disclosures. I think given the aging population and the advent of new minimally invasive techniques to treat certain diseases, the rate of interventions are expected to increase dramatically in venous disease. However, certain social economic groups are not taking advantage of management of interventions, and the literature really suggests that these disparate social economic groups fare quite differently in outcomes. Lower social economic status populations with cardiovascular disease have really been shown to have increased morbidity and mortality, whether this is attributed solely to advanced disease at presentation or a combination of advanced disease due to the lack of preventative care and delayed access to specialized treatments and procedures. It's really difficult to define. And so it's really interesting to see if the arterial work that has been done to show disparities really translate into venous disease. In venous disease, patients with more advanced venous disease tended to belong to a lower social economic status. The Neighborhood Deprivation Index, or the NDI, it's a marker that's been widely used to study the effect of social economic domains of healthcare outcomes. This study really looking at the VQI, varicose vein registry, the authors really performed a retrospective study of prospectively collected data from the VQI at tertiary referral centers. And really what we've seen here is that that what we've demonstrated is that people with sort of variables of race, of prior varicose vein treatments, all of these things were queried. And the association between social economic status and severity of vein disease at presentations were assessed with bivariate analysis and linear regression analysis. And what you can really see here that there are associations between sort of race and social economic status. Here you can absolutely see sort of the variation of that NDI, that marker for social economic status, and whether the deprivation index itself was attributed to a higher SEEP score. And you can see, especially from the right-hand side, that the patients with higher social economic scores tended to present with a lower SEEP disease class and tended to have higher number of previous vein procedures. And so in reality, it's a higher ADI, or a higher ADI means a lower social economic status had higher SEEP scores. And again, we're not really clear, is it because they didn't have access, did not have preventative care, or is it because of a lack of education? And those are all factors that kind of are clumped into this marker, the NDI. So another retrospective study that I did from 2012 to 2022 really looked at sort of 4 different areas in the United States, one in California, one in Pittsburgh, one in another place in the Midwest, and one in Washington, D.C. We chose these areas because of the fact that we have differing populations in that area, their demographics, their comorbidities, what sort of social economic status that they have. And what we really looked at is about 2,300 patients. And this multi-centered U.S. study studied that social economic status, lower social economic status, and Black race were predictive of advanced seed classification on initial presentation. And these findings really highlight the opportunity for improved mechanisms for identifying patients who are most vulnerable to venous disease, and likely the best opportunity, the best effect that we can have in intervention for this disadvantaged patient population. I thought this was also really interesting, looking at sort of during the COVID-19 pandemic, where we associated with increased risk of VTE, or venous thromboembolism. And recent studies have really showed that there are racial disparities in the incidence of VTE, especially during the COVID-19 pandemic. And this was sort of a systemic literature review to look at the number of DVTs and PEs reported by racial groups in patients hospitalized by COVID-19. And this qualitative analysis really looked at 11 studies, 6 of which included meta-analysis, and the proportion of DVT and PE events between Black and African American and white patients were actually comparable. But really, it's really important to know that anecdotally, there was really a difference. And so we really need to continue to look at these studies, especially during pandemics and things that may affect lower social economic status, disadvantaged populations more, whether that there's going to be a difference in VTE. Another study as well looked at all hospitalized patients assessed for VTE risk factors and prescribed appropriate prophylaxis to prevent VTE, really to improve sort of best practice of VTE prophylaxis. Really, the objective of the study was to examine the effect of quality improvement intervention on race-based and sex-based healthcare disparities across 2 distinct clinical services. And really what this has shown is that there are racial disparities that exist between sort of the practice of being able to give and receive VTE prophylaxis. And despite the fact that risk-appropriate prophylaxis should be prescribed equally to all hospitalized patients, regardless of race and sex, practice really varied widely before this quality improvement intervention. And so we really need to focus on what prevents equal care among all races and sexes. So I think really, hopefully this introduction really gave you a look at sort of the fact that there are all these conflicting results. And I think the conflicting results really show that there are social economic disparities that do exist among patients that we treat, and that we really have to make sure that we focus on this, especially in the upcoming years for research. Without treatment, most patients with chronic venous disease are prone to disease progression. And although some risk factors for development and progression of chronic venous disease are unmodifiable, such as age, gender, genetics, family history, other factors can be mitigated through lifestyle changes, physical activity, smoking cessation, weight loss. And there's ample evidence in literature to show that appropriate early, conservative, and interventional treatment for chronic venous disease significantly delay or prevent disease progression and provide a highly cost-effective use of healthcare resources. So really, early management of these patients is very, very important to limit the number of patients who progress in any sort of venous disease, whether it's chronic venous insufficiency, DVTs, PEs, things like that. And so numerous parameters really define social economic status. And these are really a lot of the modifiable risk factors that we really need to focus on. But it's really important to understand that there's no single variable that can quantify social economic status more than another. So it's really sort of an all-in approach. It's really important to look at the education, poor health, literacy, the financial burden, the opportunity cost of finding healthcare. Is there actually a lack of access in that area? And of course, the obesity pandemic definitely aids in this. So I think really it highlights the need for sort of a diversified approach to targeting the actual factors that improve health inequity among low socioeconomically disadvantaged patients with venous disease. I'm happy to answer any questions.
That was awesome, Ms. Saki. Thank you so much for for presenting that data. I have many questions, and I'm hoping that it raises your data and your presentation raise awareness that we need to do, as you said, an all-in approach. But before we go to questions, we're going to move to our next speaker. It is my privilege to present Dr. Preeti Sharma, who's a vascular and endovascular surgeon at Care Hospital in Hyderabad, India, and is going to be discussing a different perspective. Dr. Sharma.
Thank you. I'll be just sharing my screen right now. So, Dr. Misaki, it was a very enlightening talk, and even I have not done a study, but we get to see some similar patterns, which is there in our part of the country. Am I audible and is my screen seen? Okay, great.
Yes.
So I would really thank all of you for giving this opportunity. One is so that we could all come together and share our experiences and know each other better. So basically, I'm a vascular endovascular surgeon with interest in veins, and I do a lot of diabetic foot surgeries apart from limb salvage surgeries. Special interest is I do oncovascular surgeries and pediatric vascular, as the number of patients we are getting these days are on rise. Got some medals. In gold medal, I got it when I did my vascular surgery, and recently I have been honored with our National Board of India, where I become the coordinator. So my talk will be slightly different from the earlier one. I'll be talking on disparities, how I find disparities in patient care in terms of getting access or kind of patients which we get, what problems as a woman vascular surgeon, or what challenges to be right to mention it as we face, and what has been my experience in vascular surgery so far. I have been the first DNB for the country, and again, because of some topics which are not been uncomfortable, so I would also touch base upon certain things which have happened in the recent past which are painful. So is it a safe place to work and safe place to stay? The basic problem what we face is awareness among patients, awareness among the treating doctor. So many a times patients for venous disease or even lymphatic disease present to us very late, because many a times the patient is not aware about what is happening, and at times the patient care is compromised because the treating doctor is not aware of what is there. And so by the time they come to us, because I practice in a city which is a tertiary center, so they come to us a bit late. And the same happens for ischemic foot also, that you can see that the patients come with advanced gangrene, or at times they have a diabetic foot which is there, which is lingering around for quite some time, and they come to us. And another challenge is the kind of footwear or kind of awareness is not there. So even if I increase the blood flow, I revascularize, getting them to follow the instructions or wear the appropriate footwear is a big challenge which I am facing these days. Another issues which are something cultural or so much knit into the system is the local faiths. So certain things like people are still using these kind of things, and to my surprise, when I search, there is literature also which is printed, which is some studies are done which are not authentic, but some of them are misleading. So patients use all kind of funny stuffs on their leg, and they are not able to identify that it is not going to heal by these kind of things. So that is a challenge which I am facing these days quite regularly to break this. And late referral, obviously this young girl had upper limb ischemia, but somebody just told her put ice packs, and by the time she came to us, we had to offer her nothing more than an above elbow amputation. So there was Robbie George is a very good senior and a colleague of mine, and he came with a very interesting publication which he's done it in EJVS about what challenges we face as vascular surgeons in India and how it is changing from the recent 5 or 10 years. So it was initially thought that venous disease is a myth, but now with advances in the socioeconomic status of our people, we are regularly offering for DVT, thrombolysis, and angioplasty. But again, at the end of the day, there's a huge socioeconomic burden for the patient and family because all the patient care cost is borne by the patients themselves. Insurances and national health schemes are not that much widely present in our country. But there is a good part to it is also that in some countries there is a long waiting period to get a vascular surgeon consult. In our place, it usually happens in a day or two, and also at the same time, if it's an elective surgery, it can also be scheduled in a day or two. And there is a myth that varicose veins is not common, but there is enough data that around 30% of Indians suffer from varicose veins. So things are gradually changing, and the change is what we have seen is now the change is not only happening in medicine, it is happening in science, it is happening in research, in all fields, I would say. I can proudly say that we learned from our mistakes of Chandrayaan 2, and then this group of women scientists who were the main people who rectified those mistakes and made sure that we could land on moon. Recently, Surgeon Vice Admiral Aarti Sareen, she has become the head for the armed forces. So she is the head for Army, Navy, and Air Force. So as a woman, there is a lot of change. The environment is changing. It is much more supportive for all of us. The challenge what I have felt in my journey as a vascular is it is like walking on a tightrope, because there are certain expectations as females we are expected to do, and at the same time on the work front also we are not compromising things. So this has been a challenge for me. Another issue is, I'll just give an example, is one of the senior professors in our vascular surgery, he just mentioned ki, why should I do anything extra? Everyone knows you. So I had to make it loud and clear to him that everyone knows me as Preeti Sharma, but it is not made clear to my colleagues or my other departments that Preeti Sharma is a vascular surgeon. It is just because I am a female doesn't mean that I am to be known as a female. It's like we need to be known as a surgeon. So that is where the challenges, what I am facing or I have overcome, maybe made it into an opportunity and reached the place where it is. These two young dynamic vascular surgeons, Dr. Harita, she is a vascular surgeon in India, Dr. Indrani, who is from India, now she is in US. They did an amazing study. They did a study about what is the status of women in vascular surgery in India. And they came up with very amazing conclusions that if we have peer groups like the one which we are having now, which gives other women also a support platform on which they can express themselves, it is this mentorship and giving them priority is what is important, and it should be a gender neutral, but at the same time understanding what the male gender or what the female gender will have their limitations and which areas they should grow. So this is what right now the scenario in India, it has changed over the last 5 to 10 years, and lot of opportunities are there which are environmental conducive for both male and female vascular surgeon, which I think were not that much conducive in my training period. But I'm very happy that the younger generations, I'm able to give that environment and get more of girls to get enrolled. So in the last 5 years, the number has doubled or tripled about the females who are joining vascular surgery. So this was my experience, which I shared. We have a Vascular Society of India in which I shared, and I strongly believe that you become what you believe. So if you are persistent in doing whatever you believe, you will reach. The speed might be less, low, slow, But yes, persistence is what will take you to your final destination. Now, coming to the last brief part is about safety, because there were not so good things which had recently happened in the country. So overall, there is women safety a challenge, but if you see from the previous years, things have improved on, apart from the global front, over in the country also. So if you see, university education has become more important for girls. So which we India, we have a polling which said that 63% agree that university education. So since the education level has gone up, so the safety issues have also relatively come down, but the issues of managing home and work will always be there because of the cultural backgrounds with which it is expected of females to be more doing things or the home course. But I am sure as the new generation, the mothers are training their sons to become more independent on taking care of their home activities also. And the next maybe couple of years, if we meet again together, this ratio will again change. Thank you.
That was really wonderful. And it's amazing. You know, you really are a true trailblazer as being, you know, the first woman to do vascular surgery in India. We really appreciate you sharing your wonderful thoughts. We are going to move on to our last but not least discussion from Kirsten Schick. And she is a vascular surgeon, phlebotomist, and head of center at Gefäßmedizin in München South. And we look forward to hearing her thoughts on diversity.
Kathleen, one small correction. I am not the first female vascular surgeon. I am the first who did a certified national board course. So just I thought
sounds good.
Ready to
yeah.
share.
Thank you.
Yeah.
So thank you so much that I'm honored to be one of this great round. Thank you so much for this first speeches, and they're so interesting. I have different aspects I brought to you today in my presentation. Could you see it? All right, it's okay. You can see the presentation. Yes. Okay.
Yes.
Thank you. Thanks. So I'm in Munich right now, so I will bring you some aspects of disparities in vascular surgery and medicine in Germany. And so I was thinking about two different aspects of the differences. One of women and men in patients, so the big topic of gender medicine, where we are standing right now. And one of the topic, women and men as doctors in Germany. So I want to show you some aspects of my country here. Women and men as patients. So this is one of my passions, what I followed the last years. So I'm always happy about talking about that. So we all know the bodies of women and men are different. And it's nothing new. So the ancient Greeks already knew that women's and men's bodies are different. But however, they were convinced that women's were just the flawed version of the brilliant man. And so this is not very surprising that there were kind of weird thinking through the years. So all the centuries afterwards, until a couple of decades ago, the female patients were just behind the men. They were treated as small men, as we know. And then everybody knows her, but I just wanted to get her into my presentation because I really admire her. And I think that we should be really thankful that she made it in the 80s, Marianne Legato. And I think she did a great job, and she opens the way for the new thinking of gender medicine. So the World Health Organization put the thinking of gender medicine in the 80s in their rules or the regulations. And this is, we know, a couple of years ago. So this is nothing new. And in Germany, everything lasts a little bit longer. So we have a German version of Marianne Ligato. It's Professor Regis Saxosek. And she did over 200 publications of gender medicine. So also for patients, and now a very new, very good book for also for doctors to get trained for gender medicine. So this is something what is more new, that we also say we have to train the doctors. And so the things in Germany changed just a little, very slowly. But we also have now regulations for gender medicine in the medical studies at the university for our new students, that they learn about gender medicine through all the fields. And this is very, very new and very good that this happened. And also we have now 4 professorships for gender medicine at medical university in Germany. What I think it's really necessary and a very good changing. And we, since 2006 already, there's a German Society of Gender-Specific Medicine. So we are doing the things, but very slow. And what really is still missing is that we don't have this very special gender medicine aspects in the different fields of the medicine, of the different types. So what we started working groups in the different fields. We just started 2 years ago, the working group of gender medicine in phlebology and lymphology. So perhaps we are far behind all of you out there, but we are pretty proud that we now have the second meeting, and we have some PhD theses about female and male patients in varicose vein and the graduation of the disease when they are first met a doctor. So I think we are on a good way, and science is very good. It's necessary. We need so much more science, but I am convinced that it's very important, perhaps most important, that we are talking with the people, that we are talking and educate the patients, that they have a right to be treated in a very special way, because everybody has a right to be treated in an individual and special way he and she needs. And so I wrote a book for patients, not for my doctors and colleagues in science, but for patients, for female patients, about their legs, what difference is there, what problems they have, and how we can solve it perhaps in different ways for male patients. And I think this is something what we really have to do all together, that we educate our patients about the differences, that they can demand their doctors anywhere on the whole world, or here in Germany. Yes, second topic, women and men in doctors. That is, I think, a very, very interesting and big field. Just some data from Germany here. We have 64% medical students, female medical students. So we are more female medical students than male students right now. They're increasing all over the years. And I think this is very interesting that now there are more girls than boys starting with the medical studies, but there are still only 48 female doctors afterwards, after the studies working. And then it's a very bad number. And we all have to think about that we in Germany only have 10% female chief physicians. And this is really a shame. We have here in Munich the first female university professor for vascular surgery. So this is very good and it's the right way, but it's the beginning, it's the first one. So 10% only all over all medical fields, 10% female chief. What is that? We are missing the girls through the years. Where are we missing them? Where are we losing them? And it's still in Germany that we have some, I guess it's more or less perhaps the same in other countries, but we still have income differences for male and female. We have different career opportunities. How can you go this career ladder upwards in the university hospitals or in the other little hospitals and places? We have still in Germany, we are very conservative. We still have difficult compatibility of family and career. So the typical German we are not there anymore. So many women are working, but it's still not that easy. It's still like you show us, Pretty, with your very nice picture where the female, where the women have to go all over these problems and the men don't have that. So, and there is discrimination and harassment in the workplace. And so perhaps this is the reason why we are losing the female colleagues through the way. And perhaps it's still there that people believe that the competence in male doctors is still higher than in female. I don't know, but this could be. There was a situation, I guess all of you out there, my colleagues, my female colleagues, they will totally agree with me. The situation, male patient, and I'm going on my ward round with my colleagues, and I'm telling and talking to him. Oh, this is only a simple patient, but I was talking to him a couple of years ago in a university hospital. In the morning, ward round, I was talking and telling him about his upcoming examinations, what we are doing. And then I asked him a question, and he was not looking at me. He just turned his head, and he was looking at the male medical student in the first year, and he was talking to him. And I was standing there after, I was vascular surgeon, and I was there, and he was not talking to me because he said that it can't be me as a female doctor who was treating him. So he, at once, he talked to the male medical student in the first year. I guess everybody of you recognize the same situation. And this is the second very interesting story I went through. So what you see on this picture is my operation team. So we are all females. We are. I have a nurse and I have an anesthesiologist colleague, and this all we are a very good team together. And we operated varicose veins on a male patient. And he came up to me the next day for the regular examination. And he was a very nice gentleman. And at the end of the examination, he said, I'm very happy with the result of the surgery. And thank you so much for this treatment. But I was thinking the whole night, I was thinking about a question, and I hope you can answer. Yesterday in the operation theater, you were only female. So you were all women. You were doctors and nurses. And so I haven't seen any men. So honestly, what are you going to do if you have any problem? And I couldn't believe that he asked me that. And so I first thought makes a joke, but he didn't. He was really honestly interested in the answer. And I said, just, when we have a problem, we step out of the operation theater to the ward, and we are crying, we are shouting very loud and saying, there is a man, we have a problem. So still until today, we all in our crew, if there's any little problem in the operation theater, we just said, we need a man. And yeah, so this is something what I really experienced. And I think it's sometimes the mindset, what is very, very interesting. So what can we do? I think one of the very important things, what we do today, we are together and we are helping each other. So we should help each other. Women should help women. And this is a very, very important process that we are going through, that if we are successful, that we help the women coming afterwards. I think this is one of the very important things. So I'm at the end of my presentation. I want to say disparities, differences shouldn't bring us up to injustices. So it's very important that we recognize that there are differences and that we try to overcome old mindset. So this is a greeting from Munich. So it says, thank you very much for your listening to me.
All right, thank you, Dr. Schick. I appreciate your insight and your anecdotes. We will get to that. It always amazes me that things that happened 30 years ago to me, some people are still experiencing. But fortunately, yes, the needle is moving. But let me first start off this discussion. I want to go to Dr. Kiguchi's presentation, there's a lot of data, Dr. Kaguchi, looking at lower SES score, ADI, NDI, whatever index that you are looking at, or even zip codes, looking at different areas that are medically underserved. And I'm mainly referring to the data that I know in the United States being correlated with a higher SEEP score, probably also correlated with having more advanced atherosclerosis, cardiovascular disease, et cetera. You mentioned education, access to care, late presentations. Some of this does come down to access to care, but really fear and mistrust of the medical community. Fear in my community, fear of getting a very large bill, or having to come up with some very precious money. So how do we start educating folks, or getting care to them, so that they are presenting at lower stages where they might just need some prevention, some daily activities?
I think that's a really tough question, a loaded question, Dr. Bush.
Loaded.
I know, Dr. Bush. But I think you kind of sort of hit the nail on the head at the end, is that it's really about education and prevention. I strongly believe that. Yes, it takes away from our procedures, but I think that that's really the only way to promote equity, because a lot of this can be sort of held at bay by education. And I think when everyone is on the same playing field about having the right information, they have the capacity to make decisions for themselves. And I think that's where you're coming from, is that maybe people will make decisions. They have to make choices. And you're absolutely right. Maybe they do have to go to work instead of going to a doctor's appointment. We really don't know their situation, but at least they know that the resources are out there, and that they are educated, that they are making this choice. I think one of the most frustrating things for me is when I see a patient really far along, like when they have really bad ulcers, and they've seen so many practitioners, they've gone from their primary care to a wound care center, or, all these places. And then I tell them, well, this is a simple fix. We'll ablate this, put you in a little compression, and it'll be gone. And they've gone years. And I think that's sort of where the mistrust also comes from, is, wait a minute, I've definitely seen a lot of physicians out there, and they have not, you're the first person to tell me this. So I sense that mistrust as well, and say, who am I? Maybe you shouldn't believe me. I don't know, but I'm the only chance you got right now. But I understand that, because it's not just this lack of access sometimes as well, which I think is a majority of it, but it's really the education of what services that we can provide for these patients. And I think that's where we should really focus on, is that not only educate patients, direct to patients, but educate our frontline providers, our NPs, our PAs, I don't know how it's done in Europe, but our APPs, but also, who do these people see? Wound care folks, right? That's a visible problem that they have. They have an ulcer. So again, that's the issue that we have as well. So I think in my sort of solution to that is really to focus on education.
I think that's a very good point. One thing that we have seen where I am now is getting the education to the primary care docs, to the residents, to the mid-level providers who may be seeing, to our wound care doctors who, as you said, may have been seeing somebody for, and I see it all the time, for a couple of years, doing beautiful high-level biologics, what have you, but they need either some type of arterial or venous or both to get healed. And so so they have built a relationship with other folks. And then, as you said, who am I? One of the questions to move this a little bit further is in the chat is, are there some policy goals, both domestically, in the US or in Germany, India, that we should focus on to mitigate disparities? And I will open that up. Not politics, just policy goals.
Yeah, there are no formalized policy goals, but what as we do is the way you're doing it or you suggest it. So we have midwives, which are catering to a lot of people in a smaller society, which is a smaller village or a town. So what we are doing is we are educating those midwives, because the midwives are like kind of, we call them as Anganwadi workers. They are their first point of contact. So if anybody in the family even gets cold, fever kind of thing, so the midwife is the first person. So we are training them to teach them, like the way in India, everybody knows chest pain is heart attack. So we tell them that leg pain can be a leg attack. So in that way, ischemic wounds, especially diabetic wounds, which go unnoticed, can be picked up earlier. So this is some at a smaller level which we are doing, and that's the way, as you rightly said, not only educating the patients but educating the healthcare providers. For us, the primary care workers is very important, so that they reach us and we save on the time.
I like that, leg attack. I might adopt that. That's great.
I know. I love that. That's great. I have a question for Dr. Schick. You had talked about gender medicine as a good way to sort of teach your colleagues. And here in the United States, we talk a lot about DEI, and several of our societies have committees that are doing this. But one of the questions I had when I looked at your slide with all the ladies in the operating room, are your female staff supportive of you as a female surgeon? Because sometimes women are tough on each other.
Yes, you are asking a very, very good question. And this is the answer would be the last slide. This women should help women. And I think this is one of the problems we have to face, that you say the truth. Sometimes women are much more hard or say harder to their female colleagues than the men. I recognize when I was at university, the hardest colleague who was very tough and not very helpful was the only female doctor in the surgery team. So yes, you're right. Sometimes we are the biggest enemies of ourselves. So it's not only the men who are making the problems, so that we are making the problems by ourselves. But my individual team, we have a great team. And I think there is a question, how you are by yourself and how you are setting, is your setting in the whole team. There is this interesting study in Canada, you all know it, from 2022 about operating teams and the outcome. And I think the result was the mixed teams are one of the best teams. And I think that is, I think perhaps this is true, that we try to connect together and we try to be really a team. And I think there is very interesting how the operation team is mixed together.
My one comment about that is, and maybe I'm biased, but I, as a mom and as having a family, I almost think now of my teams in the hospital as my family. I happen to be chief of surgery, so I have a lot of male and female colleagues. And sometimes it's literally like running your home, right? Your home family, you just move it to the hospital. It's kind of like that. It's very interesting. There is another question in the chat. The question is about bias, which is what we're talking about. How does the panel suggest we approach bias in providers along the spectrum of their career and their education?
So I'm gonna comment on this. One of the slides that Dr. Schick showed, and several that Dr. Sharma showed, there are more younger persons going into medicine at our medical school. It's and across the U.S. it's been over 50% female medical schools or medical students matriculating since 2018. So the numbers have gone up. It's going to take a few years for the numbers to go up in later, more advanced positions. Kathleen and I have seen a change in the number and vascular surgeons who are women in the early career phase, those that are doing residency. The applications to vascular residencies now have gone up among women. It's going to take another generation or so for those to translate into higher positions. But what is imperative for us to do, folks on this panel, is to make sure that we support women and let them know, and the men, that they can be whatever they want to be, and their gender, where they're from, how they were, what their socioeconomic background was growing up, does not predict what they can achieve if they want to. And it's incumbent upon us to mitigate the bias. Our skin's pretty thick, and if somebody has an issue, then we take that on. We don't put that on the early career folks. That it's not their battle to fight. It is ours to promote them. It's our job to mentor and to also sponsor and give people opportunities. We don't need to give them more, educational opportunities. We need to give them opportunities for leadership, for success, and that they'll show how fabulous they are with the work. The one thing I will say about the younger generations, because my big hat I wear is being an associate dean at a large medical school, is that generation X, Y, Z, the ones that we have now, they don't see the gender imbalance the same way other generations, older generations do. They want health equity. They are in a global society. They were born in the internet age. They were born in the Instagram social media age. So they're very well connected, and they also don't want to have these biases persist. So I think things are changing, and we're going to see that whole 64% of medical students that Dr. Schick sees, in 10 years, they're going to be the practitioners. In 10 years, they're going to be the professors, and they're going to be the chiefs.
I totally agree, Ruth. I think one of the things that I really see is this, and what excites me is this opportunity that we have now, because we face bias every day. I mean, I could tell you it's 10:48 this morning, like 10 times that I was just rolled my eyes this morning. However, I think it is our job, especially in the professional setting, to sort of just lead by example. Mm-hmm. To calmly say, oh, well, that's an interesting thought, but actually, you could possibly be under a little bit of bias. You probably don't even notice it or whatnot. And then sort of as well, lead by example that we can, as females, do this. And I think that shows more than telling people oftentimes, because I think then other people will say, oh, yeah, that's right. We should. What was I thinking? And so I do think it's really, really gradual. And I don't necessarily think that bias is just, outward. I think we all have implicit bias.
Sure.
And I think that it just changes very slowly. I will tell you, I've been a program director for a while, but there are times, like Dr. Schick was saying, where I look around my OR and I see all female trainees and surgeons, and the scrub tech, the anesthesiologist, the circulator are all men. And we're working at, and I think, oh my God, I got to tell you, when I was training, that would never have happened, like ever have happened. And I don't want to say anything because I don't want to make it obvious, but I do take a moment to think, wow, I really did not think that this would be possible in my lifetime. And everyone working just, for giving the best care of the patient, no one kind of bringing it up. And I think it just happens very gradually that you kind of notice, oh, wow, I didn't really, so interesting. And I don't want to mess it up in any way, but I do think, like you said, that it's not a big, huge change. I think it's something that we do ourselves, just slowly, persistently, consistently, all of those things. I think we will see the change that we're hoping for in the next generation.
I so agree with you guys.
Yeah, I'll just put in a comment. I think the change has to be slow. And the thing is, because I suffered, the junior one who is joining the team should not suffer. Is if we keep in mind, because as being among the very few, I was the only female surgeon when I was getting trained in general surgery, only female who was getting trained in vascular surgery. So it was a kind of tough bias which I was facing at all fronts from my colleagues, seniors, and head of the departments. But when you come in that position, you make sure that because you suffered, the other generation should not suffer. So if we keep that subtle thing in mind, that change will come on. Other thing is what I have seen it is, oh, madam, you're going to operate, but you're a female and you're so young. So are you sure you are the person who is going to operate? And it's not the male who is junior to you just because he's standing next to you for the around during the consultations. But I think in our plot also, the scenario is changing. And as the newer generation, they're more adapting to the change which is happening. So it's something which is a gradual process, I think.
I totally agree to all of you. Thank you so much for this great ideas and mind and thinking. Right now, there is a very interesting. I just wanted to give a little new aspect here. In Germany, we have a new generation of male surgeons who are young and who are fathers of little kids.
Yes.
And so these groups is only a little, and this group is making a little revolution and saying that they also have a right to stay at home, of course, for a parent time, but also if there's a special, if you are at the operation theater and the child care, the kindergarten is calling, saying you have to get your kid is ill and you have to get your baby home. And usually everybody would say, okay, if there's a female doctor, it's okay if she's going. Of course, it's mom, she is allowed to go. And this young male doctors say, we would like to go also. We would like to have the same emotional rights to go if our kids are there and need us. So this is a new mindset, and things are changing. And as you say, they are changing slowly from all the sides, and it's very good.
You are absolutely right, Kirsten. And that's one thing I've seen with the medical students. In terms of parenting, in terms of taking care of family members who might be sick at home, it's now they consider their role to be just as important, and they want to be part of that family dynamic, that family time. It's not just the women. So I think this is actually going to change much faster than anything else, because they want to be involved, male and female.
I mean, I completely agree with all of you. I know we're very close to out of time, but I do want to ask Dr. Sharma a question. because again, it's in the back of my mind, some of the violence that's occurred in your country. How are women protected, maybe at the local level or at the medical school level or at the residency level, so that they're not fearful to become a surgeon or a doctor? Are there things that are being done in your country to protect these ladies?
Yes, in the last few years, especially after the first Nirbhaya accident which had happened, incident rather. So there have been laws which have become, and then there are certain guidelines which are like POSH guidelines and Vishaka guidelines, which are very much in vogue right now. So any kind of misbehavior at workplace is not tolerated, and a lot of organizations, I think the reason the things have become safer is because people who are at a leadership position or a position from where they can have some control have their working wives or daughters, so they are aware about the challenges which are being faced by the female counterparts. The elder generation, where it was like everything was males were called as the bread earners and everything, so the next generation, when they started having their wives who are working, their daughters who are going to universities, so that change has come. So in our place also there is lot of law which has come into force, and each university at even graduation or post graduation levels have these cells in which there will be people, like I'm a part of one of that cell for my institute, where a male or a female, if they have any issues related to workplace harassment, the anonymity will be kept and they are allowed to come forward and the necessary action is taken at the institution level, so they it doesn't worsen out that it becomes to a bad incident in which it ruins somebody's life or career. So things are being taken pretty seriously now. Unfortunately, the problem what happens, I think it is a problem across all the countries, is one is if any bad incident happens, the person who is suffered is feared to go to law. So many a times, if when I was talking to you earlier, is when I found out the countries in which the rape happens maximum, in that if you see there is a rape index which they say in many western countries also have it, and many a times it is that getting access to law is a challenge for many of our countries. So it is happening everywhere, but at the same time there is one generation which is coming up which is taking responsibility. So overall the law is there and people are coming more forward to report such incidents. So things are have become majorly different in the last 5 years for even our country.
That's great to hear. That is so great to hear. Dr. Osvath, should we close things out?
Yes, I think so.
All right. Well, on behalf of Venous and Lymphatic University, Dr. Kanata, Dr. Kabnick, we are so honored to be here speaking on this Saturday. I'd like to thank our speakers, Dr. Kaguchi, Dr. Schick, Dr. Sharma, for your presentations, for your insights. This has been very inspiring, and I'm so happy to virtually meet you. I'd like to thank our sponsors, BD and Boston Scientific, for promoting EmPowHER 2 to lift up voices of women around the world. And I'd also like to give everyone a shout out for our next webinar, which is going to be on November 16th. I believe it is Dr. Ricci who's going to be leading it. And it's going to be on ultrasound, how I do it, tips and tricks, again, sponsored by Boston Scientific and Vein and Lymphatic University. So thank you all and have a wonderful rest of your day.
Thank you so much, everyone.